Yes, definitely.
Anything on this test, ma'am, you would like to comment on?
Yeah, so this is NBT, very simple test which can be done in almost every pathology lab if you just get your pathologist to do it. And that is, you're like stimulating the neutrophils, and then you look at the NBT, the dye, you can see that. So this is the normal one which picks up the dye, whether the abnormal one it is not showing. So there is, you can show that reductions because of oxidative activity inside the macrophage that you're demonstrating here.
So this is one of the screening tests. The other test is DHR. Can you ask me what is the cost of this test in Bangalore? I work in a private hospital. It is 300 rupees. Okay, why do I make this statement? Because when somebody looks at the words like NBT, they are super scared. Now this is already going out of the box, so there is no need to ask for cost of it.
It is 50 rupees in a government setup, but the thing is it's so difficult to get your pathologist to do it. So because they need a fresh dye and there are all sorts of reasons why they would not do it. But I wish it's more easily available.
Yeah, but we have been able to establish, and the lab there, obviously it's a private lab, says that every day they get 5 to 10 samples. It's only about the awareness. When everyone wants to diagnose, then they start sending because it's very, very cost effective. The other test that we can do is a DHR test. And I think, Dr. Mukesh, do you want to talk on the diagnosis here?
So before we go to diagnosis, just one more comment about that NBT test. So basically it's a very simple pathophysiology which is playing there. So we normally the neutrophils produce reactive oxygen species which are useful for killing the organism. So when this so we put this dye, if this oxygen reactive species are produced, this dye is turned into blue color, else it would not be blue, as we can see here. So that is the concept behind this test. So definitely when we have this test positive, the condition which comes to our mind is chronic granulomatous disease. So there are, Aspergillus is one of the, and other organisms which we commonly see in these conditions are Serratia, Burkholdia, Pseudomonas, and also our Staph aureus. So these are the things.
So the problem in this disease is intracellular killing. There are a lot of neutrophils in the body, but they cannot kill the intracellular pathogen because of the enzyme deficiency, and you get persistent suppurative infections often in these patients. And a quick test like NBT or the DHR, the results are available within 24 hours and you have given a diagnosis to your patient. So the message, non-resolving pneumonia, please think of an immune deficiency. Unusual is the pathogen, one must work up for immune deficiency. Let's quickly go to the I think this is the last case. Yeah, 10-year-old boy, multiple episodes of pneumonia requiring hospitalization. But interestingly, each time this child got hospitalized, had pneumonia, given antibiotics, would quickly recover within 7 to 10 days. But then a couple of, I would say within a couple of years, this child would have another episode of pneumonia. And this went on for several months now. And this child also had ear discharge and repeated skin infections. Now, Dr. Arpita, recurrent pneumonia, what could be the causes? I'm sure this is something that every pediatrician deals with.
So, causes of recurrent pneumonia depend upon a lot of factors, and first of all, recurrent pneumonia is defined when there are 2 or more infections in a year or 3 or more infections at any time. Now, depending upon the first and foremost thing to establish a diagnosis of recurrent pneumonia is taking a good history. Because we have to first make sure that this is recurrence of symptoms and not persistence of symptoms. So whether the child was symptom free in between, whether the chest x-ray there was clearing in between, so to establish that it is very important. The second point about the history is what are the other associated symptoms? Does the patient have choking on feeds? Does the patient have a suck cycle? Does the patient have other multi-system involvement in the form of draining ears or recurrent diarrhea or oral thrush or oily stools or a salty kiss? So there are, so taking a good history is very important, and then in examination to see whether the child has failure to thrive, whether the child has clubbing, or any signs suggestive of allergic rhinitis. So it is very important to first take a good history to establish a symptom-free period and to see whether there is multi-system involvement, in which case it points towards primary immunodeficiencies or even cystic fibrosis or ciliary dyskinesia.
Yeah, so as rightly pointed, but I think because this child also had multiple skin infections and ear infections, some of the differentials seem less likely. Any case, when we had a look at this child had already developed clubbing, and on a closer look we could not see something in the throat that we wanted to see, and that was tonsils. So, Dr. Kaushal. Absent tonsils, boy, recurrent chest infections,
Frequent
any
infections
thoughts?
and all, we should go for immunoglobulin levels, sir. That is,
Okay, you would like to do a serum immunoglobulin levels. Yeah. Any
sir.
thoughts why would, okay. So that's the serum immunoglobulin levels here.
so all the levels are low. A gamma globulinemia, that male child X-linked A gamma
A gamma
globulinemia, we
Yep.
can suspect in this case.
So I think the
Also
diagnosis,
absent
yes sir, please sir, go on.
lymphoid tissue is absent B cells also, that points towards this.
XLA. So I think the diagnosis is as simple as this, that when we suspect, we ask for a serum immunoglobulin,
No
and if it is low,
tonsils,
it's
no
fine.
palpable lymph nodes. that
Yep.
gives
So
it-
there is no lymphoid tissue that you can palpate or you can see, and that is one of the clinical clues. But again, I would highlight recurrent pneumonia. What is the test that we do? We often do bronchoscopies. We will also do CT scan of the chest. I think the cost of CT chest should be 3 to 4K. I'm bringing the cost again and again because it is relevant. Immunoglobulins in Bangalore to me cost 1000 to 1100 rupees. Something maybe similar here in the private setup. Again, why I'm saying is, sometimes doing CT scans may not give us the diagnosis, but doing a simple serum immunoglobulin may solve the problem. Again, let me tell you, these are screening tests. These are not diagnostic tests. When you suspect, please ask for them. They will solve a lot of problems. So XLA is the prototype of B cell group of disorders. These children remain well in the first 6 months because of the transplacentally transferred immunoglobulin. There is complete absence of B cells and hypogamma. Absent tonsils may be a clue. So, recurrent pneumonia, please order serum immunoglobulins. Bronchiectasis, don't label it as idiopathic until we do a serum immunoglobulin. So, the last slide, the IC, only what the mind is prepared to comprehend. I think that is what has been repeatedly highlighted. I just want to project the last slide. And that's a small book that I've written on primary immune deficiencies called PIDs Made Simple. This was because wherever we spoke about these disorders, people asked for textbooks. And I think the STEAMS is more than 1000 pages, which I have not read. So I thought, let me pen down a small book, case-based scenarios for clinicians, for busy pediatricians, for medical students. And I thought I'll just get a couple of copies here to gift to the chairperson so that we can spread more messages. Thank you. Thank you. We can take up questions. Yeah, senior citizens.
Sir,
Sagar, I have a question before you wind up.
Yes, sir.
So we talk of PID versus secondary immunodeficiency, which is a black and white. There is a bigger zone, gray zone today of a dysregulated immunity or a multifactorial causation, whether sharing common antigens with the bugs or some subtle gene abnormality. So the diseases are becoming more severe of the usual pathogens we know. So how do we address these dysregulation immunity syndromes?
That's a very nice question. Sir is asking about immune dysregulation syndromes. Now, I think we always try to simplify things saying that immune deficiency means lot of infections. Autoimmunity means lot of autoimmune manifestations. But the new term, inborn errors of immunity, was brought to highlight that when patients have genetic defects in immune system, they are predisposed to infections, autoimmunity and immune dysregulation. Now, thanks to exome sequencing or easy access of genetic testing, these days, whenever we see immune dysregulation, we have a low threshold to get a genetic test. Now, what would we mean by immune dysregulation? Imagine a patient who comes to you with recurrent infections and autoimmune hemolytic anemia, recurrent infections and autoimmune arthritis, recurrent infections and persistent lymphadenopathy. So you have infections plus autoimmunity. Then we have a whole subset of new diseases called autoinflammatory diseases, where there is no infections, just recurrent fevers, arthritis, antibody test negative. I think today's morning session we discussed systemic GIA. That's the autoinflammatory disease. Again, many autoinflammatory diseases are being described. Genetic testing solves the problem. So I think for a clinician, when you see infections plus immune dysregulation or autoimmunity, please look for an immune deficiency is what my message would be.
Just a point on atopy, because there's so much of interest in allergy and atopy now. So atopy per se and raised IG is very, very common. But how do you tease out the ones which need further evaluation? So whenever you have refractory atopy, if you have atopy coming in very early in life, atopy with autoimmunity, atopy with infections, always consider an underlying immune deficiency. It cannot be a secondary atopy or just a food allergy or just any kind of allergy like a lung issues as well, asthma. So we even looked at around 30% of primary patients who have allergy have underlying immune deficiency. That is the kind of prevalence that we have.
Thank you.
As a general pediatrician, what are the subtle signs you look for in any common CBC just to suspect immunodeficiency in a child?
I think CBCs do a lot good if we want to suspect an immune deficiency. Number one, please start looking at differential counts. Total counts make no sense. So when we look at the differential counts, if there is neutropenia, multiple episodes of neutropenia, it could be cyclical neutropenia or congenital neutropenia syndromes. One example. Lymphocytes, persistent lymphopenia as we spoke about, it could be SCID. Persistent thrombocytopenia, it could be Wiskott-Aldrich syndrome. Very high leukocyte counts. A neutrophil count that is 70,000, 80,000. Can somebody tell me the diagnosis? LAD, leukocyte adhesion deficiency. So these are the clues that we get from CBCs. But it is often that these patients have several CBCs. Somebody has to sit with those CBCs and we can solve the problem.
Monocytopenia also. So
Yeah,
if you have
monocytopenia.
you have TB, you usually see monocytosis. But if you see monocytopenia, it is an entirely different group of immune deficiencies which have predisposition to TB.
The Zephyr model criteria now hold good with any of these three divisions, because I think it is time to revise the Zephyr model criteria, because they never differentiate between PID vis-a-vis dysregulated vis-a-vis secondary acquired immunity.
I think, sir, the Jeffrey Model Foundation did a wonderful job. They brought this criteria for public domain. It was never meant for clinicians to be used, though it became simple for clinicians to use those criteria to spread the message. And I agree with you that those criteria don't completely do justice to the broad array of immune dysregulation and deficiencies that we see today. I think
They brought out a CGD